once again, I've got that reciprocal change here that really is alarming. But what I want to make a point of here, I've got elevations, or are these hyperacute? Right? Hyperacute T waves at large T, what's it going to do to that J point? It's going to do what?
It's going to pull it up as well.
It's going to pull it up, right? So I see these elevations, but then when I look at the size of the T wave, I start to fall back on, man, I feel like these are hyperacute. They're massive in comparison to your QRS, right? And they kind of continue in continuous views from your septal into your anterior, and then they begin to dissipate again when we move into our low lateral. So here's where this one becomes sticky. Is this, by definition, a true STEMI?
I would say by definition, yes, because you do have the elevation in two or more continuous leads.
And you're referring to V2, V3?
Yeah.
Okay. I can see your argument. I guarantee you're going to get some pushback when you get to that emergency room.
Okay.
And this is the beauty of interpretation, right? Everybody here can agree on one thing. Where does this patient need to go?
He needs to go to the hospital.
Well, yes, but where? What type of hospital?
PCI.
Yeah, they need PCI, right? They need to go to the fucking cath lab.
Right.
And this is the reality of the situation. So you're going to bring this ECG in, and the ER physician's going to look at it, and they're going to say, man, these are hyperacute, and I don't have two leads that have a millimeter or 2 millimeters more of elevation, depending upon if it's a limb lead or a pericardial lead. By definition, I don't have a STEMI. So then what do you think they're going to do?
They're still going to treat them.
They're going to say, all right, I'll call the cardiologist, I'll pull a troponin, and the cardiologist is going to look at this, and you know what they're going to say? But I would say 75% of the time, they're going to say, let's wait for the troponin. Because we don't have a cookie cutter tombstone STEMI. It's the most frustrating thing that you're going to go through. Once in a while, you'll come across a cardiologist that loves getting in there. They're going to see this clear and obvious ischemic changes, and they're going to say, send them up. We're prepping now. But because we don't have a cookie cutter, clear, by definition STEMI, don't feel like you made the wrong call because it didn't make their way right up to the cath lab. I would call this a STEMI alert 10 out of 10 times. And the reason I would call it a STEMI alert is so hopefully I get everybody moving towards the cath lab, and it's up to them to derail it. Especially if they're symptomatic, right? You know, you've got your women, they're asymptomatic, your typical women fashion, they don't follow the rules of play, right? They don't do what they're supposed to do. They may not be complaining of the chest pain, things like that, the classic clinical symptoms. But man, these reciprocal changes here, they cannot be ignored. This is a patient where I'm doing continuous 12 leads. I'm hitting it, and I'm waiting for these elevations to become more profound and these hyperacute T waves to start to transition to that injury state. Now, if we see this, are we going to manage this STEMI, guys? Are we going to manage it like it's a STEMI patient?
100%.
Absolutely. And by giving them that nitro, right, what may alleviate?
It may alleviate the depression, right? Not the elevation.
Yeah, it may alleviate the ischemia, right? Because giving that coronary artery dilation, we may allow for reperfusion. So the continuous 12 leads post-nitro administration, it may begin to normalize, which is another clear identifier that we've got some type of occlusion here. But the reason why I advocate for continuous 12 leads is because, one, by seeing that alleviation, you're identifying that coronary dilation is allowing for reperfusion. Obviously, they have some severity of an occlusion going on, or MI. And two, if you start to catch that progression and that transition from ischemia to injury, you're more than likely going to validate the rapid movement to the cath lab, right? And time is muscle. That's our job. So we've got it. Our whole purpose is to call a STEMI alert to speed up the rate that we get to the cath lab. So I'm doing 12 lead, 12 lead, 12 lead, 12 lead, trying to catch that progression. So boom, I've got my my STEMI by definition 12 lead, can turn that over, right? Here's the evidence, here's the proof, get their asses to the cath lab. Man, it's a good 12 lead.